Hey everyone, my research topic was medical equipment that we'll see at the clinical site every day. Our objectives for this presentation: we want to be able to identify the different types of medical equipment we'll encounter on a daily basis. We want to be confident we can adjust the equipment in a way that will not inhibit their function for the patient, but will improve the quality of our images. We also want to proficiently move the patients from the stretcher to the x-ray table or to the wall bucky with regards to the equipment they have attached to them at the time of the exam. For example, if they're hooked up to oxygen or an IV, we want to be able to make sure they have enough room to get to the table or the bucky without being pulled. So we don't want any of that equipment to come out. So a commonly asked question is, what is considered medical equipment and what is just medical supplies? So our little chart here: medical equipment is anything used in the clinical setting that is designed for long-term use. Where medical supplies are anything used in the clinical setting that is just intended to be used once, and then you throw it away. So equipment are things like hospital beds and stretchers, wheelchairs, crutches, therapeutic footwear, oxygen tanks, vital sign monitoring devices, chest tubes, catheters, and suction. Many other things. And supplies, things that you just use once: blood sugar test strips, exam gloves, band-aids, diapers or disposable underwear, surgical gowns, and chucks or underpads. So all that stuff, not considered medical equipment. You just use it once and then you toss it. So here's examples of all different things that we'll see. In the top left, we have the chest tube disposal, and then IVs, neonatal incubator beds, catheters, nasal cannulas for oxygen delivery, different types of hospital beds. Here's the vital signs monitoring that we have mostly in the ER, but also up in the inpatient beds, and also suction. So our first bit of equipment here is the IV. It's the most common example of medical equipment that we see at the clinical site. Almost all the patients that we have on the inpatient floors in the ER, in the operating room, will all have some sort of IV, whether it's medication or just saline. It's important to be aware of the tubing when we take our portable films in our room. We definitely don't want to rip any IVs out accidentally. That would be bad. Nurses would definitely be mad at us. If the patient is hooked up to an IV, it must travel with them to the exam room. We need to be careful of how far they can walk from the stretcher and having them stand against the wall bucky for exposures. Again, don't want to rip any IVs out. Next is chest tubes. Chest tubes are used to drain air, fluid, or blood from the pleural cavity which surrounds the lungs. During chest tube insertion, a hollow plastic tube is inserted between the patient's ribs into the pleural space. The tube may be connected to a machine to help with the drainage. The tube will stay in place until the fluid, blood, or air is drained from the chest and is no longer needed. It is very important to be mindful of both the chest tube and the drainage canister when sliding the detector under the patient. We do not want to knock the canister over or lift the canister above the patient's chest. So if that happens, everything we're trying to suck out of them will go back in, and that's very bad. Next, oxygen monitoring and administration. The patient's oxygen levels will be checked by their physician by using a pulse oximeter shown in this top picture. This device closes on the patient's finger and reads the percent of oxygen in their blood. This reading will tell the doctor whether or not the patient will need oxygen therapy to improve their oxygen saturation. The oxygen tubing will be connected to the wall, where the amount can be adjusted with the dial as shown in the bottom image. That's a typo, sorry about that. On the other end of the tubing will be one of the delivery choices in the middle photo. Most common examples we see in the ER and on the inpatient floors are the nasal cannula, option 1, the Venturi mask, number 2, and intubation on number 6. It's very important to pay attention to what level the oxygen is on when transferring the connection from the wall outlet to the portable tank on the stretcher. You can see on the bottom picture there, 1, 2, 3, 4, 5, all the way up. We have to make sure that that's on the same level when we put it on the tank. These settings must match exactly for the patient to receive the appropriate amount of oxygen as ordered by their physician, because you can have too much oxygen. Next up is urinary catheters, which are used to drain urine from the body. And the most common type we see at our clinical sites is the Foley catheter. There's 4 different types of Foleys we can see on the top picture there. The catheter will connect to a drainage bag, shown in the bottom photo. It is very important to keep this drainage bag lower than the patient's bladder so that urine does not flow back up into it. The drainage device should be emptied when it is about half full and before the patient goes to sleep. When we're doing our positioning with a patient who is using a catheter, it is important to keep in mind the placement of the tubing in the drainage system so we do not knock it off the bed or somehow force it to be removed from the patient. Same as the IVs. We don't want to rip anything out of anywhere. We're most likely to encounter patients with catheters in the operating room, down in the ER, during fluoro procedures, and while performing mobile studies up on the inpatient floors. Next we have suction. The purpose of oral suction is to maintain a patient's airway and improve oxygenation by removing mucus secretions and foreign material from the mouth and throat. Patients that will require this type of equipment are those that have had a stroke, have an impaired cough reflex, have dysphagia, or vomiting while sleeping due to intoxication, or if they have been intubated. We're most likely to encounter patients who need suction in the ER or while taking portables up on the inpatient floors. It is important to make sure we do not knock the suction catheter out of place while sliding the detector under the patient. We need that airway preserved. Next we have vital signs. While the patient is staying in the hospital, they will be hooked up to a monitoring system which will tell the physicians their current levels on many important vital signs. The color-coded ECG wires will be placed at different points on the patient's torso and will read the heart's electrical signal. These wires will be the most intrusive when performing our portable x-rays or when bringing ER patients into the exam room. The wires can be seen on x-rays, so it's very important to move them out of the lung field as best we can. If we don't move the wires, and they show up in the lung field, it may be difficult for the radiologist to properly assess the films. If this happens, we may be forced to take repeat images. We'll dose the patient again for no reason. Blood pressure and oxygen will also be read by the monitoring system. These usually won't interfere with our images, but it's important to know how to remove them when transporting a patient to our exam room. And if we look at the monitor on that top picture, under the 5 there's a button for monitor standby. That's the one we press when we unhook them from everything, just to silence the monitor so nurses don't freak out when we unplug everything. Alright, next there's a few different types of beds that we'll have patients on throughout the hospital in different areas. The first is the blue striker stretchers. They'll most likely be in the ER, are used to transfer patients from their room down to our department. It's important to be familiar with all the pedals, all the handrail adjustments, so we can properly transport and position the patient throughout our exams. The pedals I use most often down in the ER, especially sliding patients. We'll pump them up, pump the bed up, and then drop either the head or the feet down by themselves, and then slide them easier. It helps. A second type we find has the red or maroon mattresses. They'll be on the inpatient floors. We'll see those when we're up doing portables. These beds will be plugged into the wall. They'll have controls for the movements up and down, moving the head up and down. It also has a zippered pocket on the side for us to slide the detector in, so we don't have to go right underneath the patient. It makes our job a lot easier. And the last type is the sand bed, which can be tough to use, but they're very good for the patient. They're used for patients who cannot move on their own, making them highly susceptible to bed sores or ulcers. These specialized beds, it pushes air around millions of tiny beads, creating a fluid-like surface for them to lay on. This constant motion reduces the risk of the patient developing sores from lying in the same place for too long. It's very difficult to slide our detectors underneath the patient, and this type of bed usually gets stuck in the material, all the beads. So to make it a little easier, we can momentarily shut the motion off by either using the foot pedal, or there's also a button on the side of the bed. And last we have the neonatal incubator beds. When we're doing portables in the PD rotation down in the NICU. These patients will be very small, therefore their body temperature will not be high. This makes the use of heated beds necessary for them. When taking our images, we can either use the tray that slides out from under the mattress, or the nurse can pick up the baby and place them on the detector. We don't want to place them directly on the detector, though. It's important to have a blanket or a pillowcase between them, because it will feel very cold to the baby. And when they get cold, they cry, which isn't good for us. It's also important to pay attention to what type of bed the babies are on. The one in the top photo has an overhead heater that can be swung either direction by pulling the knob on the back of it. Some other beds have a fixed overhead heater that can't be moved. When dealing with this type of bed, we must work quickly because the heater can actually melt the casing of the tube head when you put it under, which has happened. There are my references, and we'll have some questions coming up soon. Thank you.